Not every GLP-1 is the same drug. You can have a valid prescription, fill it at a licensed pharmacy, and still walk away with something that delivers less than half the weight loss it was supposed to, or in the worst cases, something that sends you to the emergency room with your blood sugar near zero. The GLP-1 category has become one of the most talked about drug classes in history. But inside that category, there is a spectrum that almost nobody discusses. On one end, drugs that technically work but barely justify their misery. On the other, products so dangerous that the FDA has spent the last 2 years seizing them from pharmacy shelves. By the end of this video, you will know exactly where every version of this drug sits on that spectrum and the one question that matters more than which drug to take. This is that spectrum, ranked from bad to worse. Number 1. Byetta, also known as exenatide. This is the GLP-1 that started it all. Approved in 2005, it is the oldest member of this drug class still in active use, and it shows its age. Here is what Byetta asks of you: 2 injections per day, every single day, 1 before breakfast, 1 before dinner, 14 needle sticks per week in exchange for an average weight loss of 2 to 3 kilograms over 6 months. The newer drugs in the same class deliver 10 to 15% of total body weight lost with 1 injection per week. Think of it like buying the original 2005 GPS unit when your phone already has real-time mapping built in. The old device technically works, but you are committing far more effort for a fraction of the result. But here is the problem that does not appear in the brochure. Byetta carries a black box warning, the FDA's most serious category of alert for thyroid tumor risk. And among all GLP-1 drugs on the market, it produces the highest rate of pancreatitis, a dangerous inflammation of the pancreas that can require hospitalization. Clinical records document patients whose pancreatitis resolved when exenatide was stopped, then returned immediately when it was restarted. Maximum daily commitment. Minimum clinical return. Highest risk profile in the class. Number 2. Saxenda, also known as liraglutide. Saxenda keeps the same fundamental problem as Byetta. It is a daily drug in a world that has moved to weekly ones. But the real damage is in the numbers. In a direct clinical trial, participants on Saxenda lost 6.4% of their body weight over 1 year. Participants on semaglutide, the active ingredient in Ozempic and Wegovy, lost 15.8%. Same drug class, same daily commitment, less than half the result. Think of it like paying full fare for a flight and only making it halfway to your destination. You went through the whole process. You just never arrived. But the number that tells the real story is the dropout rate. In the same trial, 27.6% of Saxenda participants quit due to side effects, nearly double the 13.5% on semaglutide. Saxenda has a shorter half-life. The window of time the drug stays active in your system, which means hunger comes back sharply between doses. The drug peaks and troughs every 24 hours. Your appetite follows that same cycle. This is why nearly 1 in 3 people who start Saxenda quit within a year. Number 3. Rybelsus, oral semaglutide. Rybelsus is the only GLP-1 that comes as a pill. No needles, no refrigeration. That sounds like an obvious upgrade. But the pill format comes with a catch so severe that most people using it are getting almost none of what they are paying for. The bioavailability of Rybelsus, the fraction of the drug that actually reaches your bloodstream, is between 0.4 and 1%. If you take the standard 14 mg tablet, your body absorbs the equivalent of roughly 0.1 milligrams of active drug. Here is why. Semaglutide is a large protein molecule, and the digestive system is designed to break down protein. To get any of it through, Rybelsus is co-formulated with a special absorption enhancer called SNAC, salcaprosate sodium, which creates a brief chemical window in the stomach lining for the drug to pass through. That window is extremely fragile. You must take Rybelsus on an empty stomach after fasting for at least 8 hours, with no more than half a glass of water, because too much water collapses the absorption window before the drug can pass. Then you must wait 30 minutes before eating anything, drinking anything other than water, or taking any other medication. Food or coffee within that window closes the pathway entirely. In one clinical study, 14 out of 25 participants who took Rybelsus in the fed state showed 0 measurable absorption of the drug. 0. This is not a pill you swallow with breakfast. This is a pharmaceutical obstacle course, and most people are failing it silently every morning, wondering why the drug is not working. Number 4. Compounded semaglutide. This is where legitimate medicine ends and the gray zone begins. When the FDA declared the Ozempic and Wegovy shortage in 2022, it allowed compounding pharmacies to produce their own versions of semaglutide. Thousands of pharmacies entered the market. Some versions were reasonable. But here is what the FDA found. Compounded semaglutide came in multi-dose vials with no standardized concentrations. Some pharmacies instructed patients to inject in units, the measurement system used for insulin, not milligrams. Those are different scales measuring different things. The FDA received reports of patients self-administering doses 5 to 20 times higher than prescribed, not because they were reckless, but because the measurement system on the vial was incompatible with the drug inside it. Think of it like a prescription written in miles being filled in kilometers. The number looks the same. The dose is catastrophically different. In August 2024, a patient noticed a black particulate floating inside their vial of compounded semaglutide. The FDA traced it to Fullerton Wellness, a pharmacy using non-sterile ingredients with no sterilization steps at any point in production. That same month, more than 15,000 vials were recalled by ProRx for the same reason: no sterility assurance. By early 2025, the FDA had logged more than 455 adverse event reports linked to compounded semaglutide. The drug might be real, the dose might be correct, the vial might be sterile, or none of those things might be true. There is no way to know from the label. Number 5. Research-grade peptides, the bodybuilding pipeline. This is where we leave licensed medicine entirely. As GLP-1 demand exploded and prices climbed, a parallel market emerged through online fitness communities and supplement forums. They sold what they called research-grade semaglutide, or tirzepatide, powder form, shipped in unlabeled vials, meant to be reconstituted at home with bacteriostatic water. No sterility testing, no verification of contents, no accurate dosing. Sold as for research purposes only, a legal phrase that means nothing once the substance enters a human body. In September 2025, the FDA reported cases of these products containing unapproved foreign substances, compounds that were not semaglutide, tirzepatide, or any known GLP-1 drug. Some were other peptide compounds, some were entirely unidentified. The person injecting had no way to know. Think of it like getting your car's brake fluid from an unlabeled jug someone sold you online. You can put it in, but you have moved every consequence of that uncertainty entirely onto yourself. Number 6. Counterfeit Ozempic. Inside the legitimate supply chain. Here is where this story should stop most people cold, because what comes next is not the black market. It is a licensed retail pharmacy in the United States. In December 2023, the FDA seized thousands of units of counterfeit Ozempic from within the legitimate U.S. drug supply chain. Products that had moved through authorized distributors arrived at licensed pharmacies and were sitting on shelves ready to be dispensed. The pen looked authentic. The lot number was correct. The hologram was there. But the FDA confirmed the needles were counterfeit, meaning their sterility could not be verified. Every injection was a potential introduction of bacteria directly into subcutaneous tissue. In April 2025, several hundred more units entered the supply chain. In December 2025, a third wave was seized. 3 confirmed incidents, 2 years, all inside the licensed supply chain. The only way to identify counterfeit Ozempic is one visual detail. On the authentic pen, the EXPLOT text appears above the expiration date. On the counterfeit, it appears to the left. One line of text in the wrong position is the only thing standing between a patient and an unverified needle. Number 7. Counterfeit Ozempic containing insulin glargine. This is where the list stops being about drug quality and starts being about emergency medicine. In June 2023, a patient purchased what they believed was legitimate Ozempic from a retail pharmacy. The label read semaglutide. The contents were insulin glargine, a long-acting insulin used to manage blood sugar in diabetic patients. For a non-diabetic person injecting what they think is a weight loss drug, that same dose works the way a fire hose works on a candle. Insulin forces blood glucose, the primary fuel the brain runs on, out of the bloodstream and into cells. In a non-diabetic person, there is no elevated blood sugar to correct. The insulin drives normal blood glucose down anyway, and nothing pushes back. This is severe hypoglycemia. A blood sugar drops so deep the brain begins to run out of fuel. Confusion arrives first, then loss of coordination, then unconsciousness. The patient experienced an adverse reaction. The case triggered an FDA investigation that led to the December 2023 supply chain seizure and the ongoing counterfeit monitoring program that continues today. This is what the far end of this spectrum looks like. Not weaker results, not worse side effects. A completely different drug in the pen, one capable of causing a neurological emergency in someone who has no idea it is happening. Every step down this list is a step away from clinical oversight and towards something less controlled, less verified, and less safe. The demand for GLP-1 medications is so large and the legitimate supply so constrained that an entire parallel market has built itself around that gap. One that looks like medicine, ships like medicine, and in the worst cases contains something entirely different. If you're using or considering a GLP-1, the most important question is not which drug performs best on a chart. It is where the drug in your hand actually came from, and whether anyone who made it was held to any standard at all.